Actually, from our database, aneurysm concept is very effective to achieve the complete healing. So amputation-free survival, limb salvage rate were significantly higher in the direct revascularization group, which meant that one straight line flow to the toe or to the wound based on the aneurysm concept. So it's very useful if you treat the CLI patient based on the aneurysm concept. I think it's very useful. Also, does not move. Okay, go back. Okay, Gabriel, the representative case, he had a true ganglion. With an infection, I recommended to receive the bypass surgery. Here is a bypass graft connecting to the dorsal spes artery. After the successful bypass surgery, he received a minor amputation at the metatarsal level. During 3 to 4 months, I performed the back to make a new granulation. You can see the good granulation after the 1 month. However, 2 months later, you can see the difference of the result between the dorsal side and the plantar side. Although patient receives the bypass surgery, the result is different. This patient is a dialysis patient. If this patient not in dialysis, non-dialysis patient, result is maybe different. But aneurysm concept is also important for the dialysis patient. Because why? Because in dialysis patient, A-to-A connection between the dorsal side and the plantar side has been already collapsed due to the many calcium and many atherosclerotic occlusion. Therefore, if the patient receives a successful bypass surgery, you can see the good granulation at the dorsal side, but we can not see the good granulation at the plantar side. This is an aneurysm concept. It's a very simple, good blood flow supply, great granulation. You can see so no blood supply, no wound healing. So also you can see that at the heel, new CLI was found. Also below the ankle artery disease, angioplasty is a very helpful and useful to make one straight line floor. I will show you the case, 83-year-old female who received a minor toe amputation of the second toe. However, it did not heal. Here is the angiogram of the left side. Dorsal spes artery was occluded, so I opened it. So you can see the wound healing has been starting after the successful angioplasty, but 2 months later just stopped due to the reocclusion of the dorsal spes artery. Therefore, I reopened dorsal spes artery again, but additional 3 months later just occluded again, so we can perform the endovascular procedure to open the dorsal spes artery again. So to achieve the complete healing, it takes 7 months. So aneurysm concept is very important, but it's not perfect because after the endovascular procedure for below the knee artery, restenosis rate was extremely higher. Dr. Schmidt and we also investigated that 3 months restenosis rate after the angioplasty for the below the knee lesion was 70%, around 70%. But But the average of time to wound healing for Rutherford class 5 and institution was 150 days, nearly 4 months. Therefore, in some cases, repeat revascularization is needed to achieve the complete healing. How many below-the-knee arteries should we treat? Let's talk about the probability of keep it open. So if you treat, as I mentioned earlier, the 3 months risk analysis rate was 70. So if you treat one vessel, 3 months later, 70% were restenosis or occluded. So remaining 30% seems to be open. So if you treat the 2 vessel for the below the knee, maybe in half of vessels, 1 or more treated vessel seems to be open. If we treat the 3 all vessels, maybe 2/3 of the treated vessel, 1 or more seems to be open. But we should keep in mind the remaining 1/3 patient, 1/3 vessel has been occluded at all. Therefore, these region make it worse of the lesion, of the wound. This is a summary about in terms of the aneurysm concept. One straight line flow based on the aneurysm concept is a very useful and helpful if you can perform the endovascular procedure, but it's not perfect yet. I think aneurysm concept is a good indication for the rest pain, or rather for the class 5, so small tissue loss, or with a good below the ankle runoff. So, however, so for complex patients such like a dialysis, diabetes with a big tissue loss, with an infection, for such like a patient, I believe so you should open more and more vessels, as many as possible. Thank you for your attention.
The goals of treatment for critical limb ischemia is to improve limb perfusion so as to relieve pain, heal wounds, preserve a functional limb, and maintain an ambulatory status when that is possible. Or alternatively, it is perform an above ankle amputation if in fact revascularization ideas and plans are futile. When you talk about revascularization, there's open vascular surgery, there's endovascular surgery, and there are hybrid procedures which are combinations of the two. In terms of open vascular surgery, we have inflow bypass that is sometimes necessary, something like an aortobifemoral bypass, an endarterectomy, which is often necessary, typically in the common femoral artery, but the infrarenal bypass is really the workhorse of open vascular surgery for critical limb ischemia when it's needed. Open vascular surgery is the traditional treatment. It has durable outcomes. Long follow-up periods are available, but it is invasive. It is associated with blood loss, morbidity, mortality, and wound complications. Endovascular surgery, of course, involves a plethora of new devices and techniques that are coming to us almost at a monthly basis, and of course, a big part of this course is dedicated to these. Now, endovascular surgery is minimally invasive. There's no need for general anesthesia, incisions, hospitalization. There's definitely lower morbidity and mortality compared to open surgery, but there is decreased durability concerns, low patency rates in some vascular beds. Often nephrotoxic contrast agents are needed. It is expensive, and it is driven by business interests, so conflict of interest is often an issue. So how does one decide between endo or open in patients with critical limb ischemia? Well, when you turn to the literature, it's not very helpful. There's a lot of literature out there, but most of it is retrospective, poorly controlled, poorly powered. The endpoints that are used in this space are suboptimal. There's sponsor bias, operator bias. Often claudicants are included together with CLI patients, and the follow-up leaves much to be desired. There's only one controlled randomized trial in this space. The BASIL trial was conducted at the turn of the century in the United Kingdom. Its aim was to compare outcomes of surgery-first strategy with angioplasty-first strategy in patients with severe limb ischemia. And BASIL investigators found that there was no significant difference in amputation-free survival, which was their primary outcome at more than 5 years of follow-up. There was a trend towards benefit for surgery in those patients who survived more than 2 years. Although BASIL was a valiant effort on the behalf of Professor Andrew Bradbury and his team, it was underpowered. Endovascular therapy was limited to angioplasty alone, making it obsolete almost immediately. There was lack of lesion standardization, and amputation-free survival, although a common endpoint in the space, is not a great endpoint when you're comparing strategies. And so it is no surprise that a recently published meta-analysis by Skylar Jones and Manesh Patel of endovascular and open surgery and comparative effectiveness studies of these two techniques found that there's paucity of high-quality data that is available to guide clinical decision-making. Well, we wanted to know how physicians decide between surgical bypass and endovascular therapy in critical limb ischemia, and to what degree of equipoise there's a range across these clinical scenarios. And so we administered a survey a few years ago to a group of vascular surgeons. Now, I just want to digress for a second to define clinical equipoise. It can be defined as a state of honest professional disagreement amongst a community of experts about the preferred treatment. And so 76 of 100 surveyed surgeons filled out the survey. Most of them were academic surgeons. The majority were at least 10 to 20 years out from their fellowship, and the majority did both open and endovascular therapy in their practice, almost equally. In terms of demographic and clinical factors, things like presentation, end-stage renal disease, there was significant equipoise in terms of what these surgeons thought whether bypass or endovascular therapy was appropriate. So in a striped column is equipoise, black is endo, and tan is open surgery. So you can see there's equipoise throughout, possible exception of older age. Most folks thought that when the patient is older, you may want to lean more towards endovascular therapy. In terms of SFA Task 2 classification, the respondents felt that for Task 2A and Task 2B lesions, endovascular therapy ought to be applied. For Task 2C lesions, there was significant equipoise. And for D lesions, open surgery ought to be the appropriate therapy. In terms of availability of vein, well, there's no autogenous vein present. The majority felt that endovascular therapy was appropriate. When there was suitable single-segment great saphenous vein present, that's the best possible conduit for bypass, half thought that surgery was appropriate, but there was a significant amount of equipoise. And then finally, in terms of arterial anatomy and various anatomical factors such as severe conformal disease, flush SFA occlusion, presence of a popliteal artery occlusion, small infringement arteries, and so forth, there was significant equipoise across all of these markers with the exception of conformal disease, where the majority felt that patients with conformal disease ought to be treated surgically. And so there's no surprise that you see this slide here. This slide comes to us from the Vascular Quality Initiative that is now composed of more than 360 vascular centers across North America. On the x-axis are VQI centers. On the y-axis is percent of patients with CLI and femoral PAD treated using surgical bypass. There's huge variability. There are some centers that do almost no bypass, almost all endo, and there's some centers where do almost no endo, and almost bypass, and everything in between. And this is why we're running the best endovascular versus best surgical therapy in patients with critical limb ischemia trial, which is a prospective, randomized, multi-center, multi-specialty, open-label superiority trial that aims to enroll 2,100 patients at 140 clinical sites in North America. It is funded by the NHLBI, and its goal is to assess outcomes, quality of life, and cost in patients who are candidates for both open vascular surgery and endovascular surgery. What questions will best answer? How bypass with excellent vein compares to endovascular therapy? How bypass with suboptimal conduit fare? It will assess comparative effect of clinical presentation and anatomy, comparative quality of life and cost effectiveness, and outcomes of revascularization as it relates to a multitude of factors. This is just a partial list. It will prospectively validate the SVS Wi-Fi wound classification and relate comparative hemodynamic outcomes of revascularization to clinical outcomes. It will define an evidence-based standard of care that currently, unfortunately, does not exist in this space. As of yesterday, 528 subjects were randomized, which is a quarter of where we need to be. Now, BEST CLI leadership is collaborating with Viva physicians to develop a robust CLI registry, which will include patients who are screened for but excluded from BEST. It will be enriched for patients at high risk for open surgery and those with advanced anatomical disease patterns. We plan to bring 5,000 patients to BEST CLI sites into the registry, and the registry and the randomized trial will capture a real-world cohort of CLI patients in a complementary fashion. The registry, I believe, will provide a clear context for the randomized trial. Across the ocean, there's a lot of activity as well, because BASIL 2 is also happening, and that is a trial that's comparing vein bypass first versus BEST endovascular first in patients with severe limb ischemia and infrapopliteal disease. And as the plan is to enroll 600 patients. As of yesterday, when I last communicated with Professor Bradbury, he enrolled 136 patients at 47 sites, again, a fourth of what he needs, which is very similar to where we are, even though we started both at the same time. Now, how do I decide between endo and open in patients with CLI before this valuable level 1 evidence becomes available? Well, I think of the patient, the limb, and anatomy. For patients, I think of ambulatory status. Are they walking or are they not? Comorbidities, their estimated life expectancy, and whether or not they've had prior vascular interventions. For the limb, I consider how bad the tissue loss is. Is it a small wound or is it significant gangrene? And for anatomical factors, I consider extent of occlusive disease, lesion length, degree of calcification, whether or not there's a target present, and whether or not there's good vein present. Basically, ambulating patients with large wounds, few comorbidities, longer life expectancy, multi-level diffuse occlusive disease, and single-segment great saphenous vein get open vascular surgery in my practice. Patients with smaller wounds at high surgical risk, shorter life expectancy, less extensive occlusive disease, no good vein, get endovascular surgery. Patients with poor functional status, multiple comorbidities, short life expectancy, extensive tissue loss, get primary amputation in my practice. So in conclusion, there is absence of good data to guide treatment of critical limb ischemia today. The BEST trial will provide a treasure trove of invaluable data on CLI and its management. The Viva BEST registry will provide vital information about patients with CLI who were not enrolled into the randomized trial. BASIL 2 will nicely complement BEST, and patient limb and anatomical factors are used to decide on CLI therapy in the current data void. Randomized controlled trials are imperfect, but they're the best science that we have. It is not a GPS to replace clinical judgment, but a valuable compass suggesting the right general direction of travel. Thank you.
You just saw Alec give an expert commentary on the balance between open and endovascular therapy for CLI. He mentioned 3 basic pillars, that of health and individual patient risk. He mentioned limb status and the severity of the limb threat, as well as anatomy, and I'll try to walk through each quite quickly. 20 years ago, we had a progression and an understanding of the natural history of peripheral arterial disease. We've built upon that in the last several years with the publication of multiple risk models that allow you to predict outcomes of amputation-free survival and overall mortality. Let me just review quite briefly some of the pertinent issues regarding these risk models, everything from PREVENT-3 to actually Dr. Soga's excellent paper. They've used amputation-free survival or just patient survival as a primary endpoint. Time of event is between 30 days and 2 years. Verified interventions are different. Some studied bypass patients and some studied both endovascular and surgically treated patients, and some just looked at the interventional populations in different origins of the population, which is quite important. This busy slide, but the take-home message is that the variables first analyzed in a univariate fashion and then applied to a multivariate analysis were quite different in each of these risk models. Likewise, some were done over 10 years ago as well that point to the fact that perhaps the studied population now, as you've seen on some of the more elegant talks this morning, are different than what we can apply today. So there has to be a continual recalibration of models as we go, and the most recent of which is ERICVA that was published here in 2016 that looked at some very unique calibration models such as active cancer. Often there's very little published in the CLI literature on these type of patients. This neutrophil lymphocyte ratio has a high risk and adverse impact on mortality. Certainly Rutherford 6s in those with a hematocrit of less than 30 and is very predictive. And if you look at the area under the curve, let me just show you a slide that briefly describes this in the ERICVA risk model. If you just take those 6 simplified variables, and if they had 0, they were on the blue line. If they had 1 variable, they're on the green line. If the yellow line points out that those with more than 1 risk model, there's a great stratification in regards to what the overall mortality or risk was to the patient. How do you interpret area under the curve type lines is given there in the top bar, where the red line, when the sensitivity and specificity are compared and you're way over to the left, that's a great model. Those that fare like the blue line are poor, and those in between are kind of in the fair category. And I would suggest that all of our risk models still fall in that fair type of category. We don't have the best model to predict mortality in these patients. But let me simplify it even more. We know that hazard ratios are quite comparable from study to study, and those patients that have a very poor walking distance, cannot walk very far on a 6-minute walk test, have very high odds ratio compared to those that can walk much further, or their functional status is very predictive of overall mortality. Also, a new concept of sarcopenia, in which low skeletal muscle may have a significant prognostic experience significance. As you know, almost everybody gets a CT scan for shoe size anymore when they walk in the hospital. So we've got tremendous additional information that may be readily available without having to pose too much additional work. Just a few references for you in regards to the impact of functional performance on overall mortality. If patients don't walk, they have a much higher mortality rate. And that's part of your thumb test. You just kind of know. You walk in a clinic, you see a patient, and that is just something that comes so natural to you. You get a sense of what their functional status is, and that's quite predictive. Just highlighting this notion of sarcopenia. What is it? If you take your CT scan and at the mid-body of L3, you outline the muscles, the paravertebral muscles as well as abdominal muscles, and quantify it. You take a threshold and you take the bottom 20 percentile, create a threshold to label someone as having very low skeletal muscle mass versus somebody who has adequate skeletal muscle mass. You see the survival curves are quite different, even in the small patient subset, that 5-year survival is quite low in those with sarcopenia compared to those without. When you combine sarcopenia with other risks such as age, hemodialysis, cerebrovascular accident, what you find is sarcopenia in and of itself. Many of those are descriptors of patients that would have sarcopenia. If I've had a stroke, I'm non-ambulatory, I'm much more likely to lose my skeletal muscle. So once again, just looking at the CT scan and getting a sense of overall muscle volume may be quite helpful. Moving on to the limb category, I think it's really helpful. This Wi-Fi classification hasn't been mentioned, I don't think, yet this morning, but it's something that you should reference. It's put together by our vascular surgery colleagues, and what they tried to do is not only consider ischemia, as mentioned by the hemodynamic markers there, but also infection grade. There's a big difference between cellulitis and heel necrosis in regards to wound grade, and infection, a big difference between some cellulitis and a systemic infection. And it can be graded, and then you can classify patients according to their overall picture of being in stage 1, which is very low risk, and stage 4, which is very high risk, which would carry perhaps a mortality at 1 year of up to 40%. But what this does is it provides us with a line of calibration for us to go look at our own population and compare. How are we doing? If we call the wound and the infection and the ischemic risk commonly, we'll be able to compare our results individually and institutionally to those that are published. And then finally, the anatomy. There's anatomic scales that look at lesions. There's anatomic scales that look at limbs. And realize that patients with critical limb ischemia, 2/3 of them have both superficial femoral and tibial disease, whereas 1/3 of them only have isolated tibial disease. When you hear commentaries on, well, I just need enough circulation to get the wound to heal, unfortunately, I believe that patency matters. And longer-term patency probably matters to minimize your risk of recurrent ulceration and possible subsequent limb loss. I'd offer you these, and this will be available online, lesion characteristics that make anatomic variables more or less favorable for endovascular therapy. And it stands to reason. A very favorable lesion would be one that's short in a big vessel with great runoff versus one that's less favorable that has virtually no runoff. Patient won't take their medication, and it's a very small vessel. In the tibial artery, slightly different characteristics in that we have a harder time defining what is a short versus a long lesion, but let's just divide it up into thirds. Let's take the larger vessel as the 3 millimeter or greater, and the smaller one is less than 2. Calcification is quite different, and most importantly, can I provide direct flow to the ulceration in the foot? We have some appropriate use criteria. They're there, they've been published, they haven't been bashed too badly in the literature yet, and we do need to continue with this type of dialogue in regards to what is appropriate indications for our endovascular therapy. So I leave you with this summary slide. It's all about the patient. We start with the patient, we end with the patient. We go through a risk assessment, assess the severity of the limb with Wi-Fi, look at the anatomic burden, understand where it works well in your hand versus someone else, and stop and reason. We're physicians. So I'll thank you with that.
I'd like to start with an email that I got from one of the hospital administrators last fall, in which he said, "Good morning, gentlemen. In the case," he's referring to a specific case that we had done, and he said, "In the case we used 3 Zilver PTX and 2 Xiant stents. The bill has cycled through and we lost $10,654 on that one case. We really need to scrutinize the medical necessity of these high-cost implant cases, as financially we are not positioned to absorb this kind of loss." And then the person who was copied on the email and responded, he's our chief operating officer, who is as stingy with his words as he is with his finances, who sent a one-word email back saying, "unsustainable." Well, the question is, where is this unsustainability? So let's look at this one case, which I think is representative of many of the patients that you take care of. This is a 69-year-old guy. He's a retired construction worker. He had presented with left foot rest pain and discoloration after he had already failed a FemPop graft. And when the FemPop graft failed, he had a profunda angioplasty, which also was followed by failure. His anatomy included occlusion from the origin of the SFA all the way to the anterior tibial, and he had been offered amputation. So this was the clinical situation he was in when we did this costly procedure. And now our biggest problem is we can't get him to come back to clinic because he says he feels too good and it's a waste of time to show up for a clinic appointment. So looking at this from the hospital standpoint, they were saying, well, what you did was really costly, but we could have done this above knee amputation for a DRG 241, and we easily could have made a profit with a DRG of $11,245. So they're looking at it in a different way. Well, probably the best thing that we could use to put this one case in a longer-term context was this study, which was published 2 years ago by Barshes, in which the various outcomes and costs were compared. So here you can see, if we look at amputation in the center, The 5-year survival is 24%, almost identical to that with a primary strategy of either wound care or endovascular, which we've chosen in this option. But if you look at the next column, 5-year limb salvage, obviously with amputation it's 0, whereas with an endovascular approach you've got a 2/3 chance of still having the limb intact. And years of ambulation, you get almost 1 additional year of ambulation with an endovascular approach. And then if you look at the far right column, you can see the striking finding, which is that the total cost was most expensive with amputation as the primary strategy, with wound care and endovascular being comparable. Alec mentioned the BASIL trial. If you go down to the very last line here, there was a higher cost associated with surgery as compared to an endovascular approach. So another point of support for an endovascular approach when we look at various options for these patients. Now, one of the things that's really essential in understanding healthcare economics is to step back and see what motivates different players in this environment. So we have to understand the financial incentives. When they are aligned, all the players have the same objectives. The patient, the hospital, the payer all want the same thing. The reality in healthcare in the United States is that it is typical to have poor alignment, and remarkably, it's very common to have opposite alignment, where one party wants one thing and one party wants exactly the opposite. So let's look at this through different perspectives. For the insured patient, looking at things from a financial incentive standpoint, this person wants the most durable outcome regardless of the cost. For the payer or the self-pay patient, they want the slide to advance. There we go. The lowest long-term cost is what is desired. And it's important to emphasize that a higher initial cost is okay, provided it's offset by savings later on. For a hospital or for an office-based lab, they want the lowest cost per procedure, no money-losing procedures, and the greatest number of profitable procedures. For physicians, looking at this just from the standpoint of finances, they want lots of procedures, and higher paid procedures are better than lower paid procedures. And they're, in general, concerned about equipment cost only if they're directly affected, like in an office-based lab, or indirectly affected through some means of an incentive or a disincentive for using more costly or cheaper materials. Many interventionalists really have no idea about the cost of the equipment that they use in the case, the total cost of the case, or the downstream cost after treatment has been undertaken. So many people don't know that a sheath costs $9, a commodity balloon is $98, or the other prices that you see on this slide, for a total cost for a simple angioplasty and stent of $815. Nor do they recognize some of the variabilities in cost. So here on this slide, you can see for the cheapest stent, $700. And as we go up, we can see that the difference between the cheapest stent and the most expensive is a 5-fold difference in cost. Very often outside the US, we see devices aren't used that we use commonly, and often that has directly to do with cost. So if you look at some of the costs of the things that are involved with more complicated procedures, you can see that these costs are really substantial and sometimes prohibitive. So why is it important that those of us who care for patients know about these costs? Well, first of all, we have to understand that Medicare is the single biggest payer for healthcare services in the US, and they work under a fixed payment scheme, whether it's a DRG or an APC or for an office-based lab. They give a certain amount of money, and that's all the money that's going to be there. For office-based labs, this can have real impacts on how healthcare is practiced. There's no additional reimbursement for DES or DEB, for example. Let's look at what this does in terms of the cost to the institution of using different equipment. So in one scenario, given an APC or an outpatient hospital procedure where the hospital gets $9,600 to do the case, If you use cheap equipment, the hospital has $8,800 left over after the case is performed. If you use a couple of PTFE-covered stents and maybe a more expensive balloon, that remaining amount drops to $2,300. If you use a more complicated scenario, woven wire stents, a crossing device, and a reentry catheter, now there's only $900 left over. So we have to ask, can we figure out, is a new therapy worth it? And actually, you can compare these if you make certain assumptions based on the medical literature of what certain therapies cost. For example, if we use angioplasty as our base, we can see that a bare metal stent is in the same ballpark if we look at the far right-hand column of follow-up plus the initial cost, whereas drug-eluting balloons are even less expensive. A drug-eluting stent is the next most economical way to go, but atherectomy has really terrible healthcare economics. So that atherectomy would still be the most expensive even if there were a 0% TLR rate. So what we're dealing with often is that patients and payers want the opposite of what hospitals want, and physicians may get paid more for things which really don't have good medical support financially. So in order to make this insanity a little bit more sane, CMS is starting to do some things that make sense. For example, paying more for an inpatient drug-eluting stent or paying for any drug-eluting balloon used within a hospital setting. There are also some ways to share risk, which also are helpful. So to summarize, financial realities place significant pressure on the idealism that we all had in training about how to best treat patients. Ultimately, using the golden rule, treating patients like you would want to be treated is still the best practice pattern. And overall, no matter what, it pays to know the numbers. Thank you.